Hi, this is Dr. Akhtar Amin and today's topic is viral conjunctivitis. Viral conjunctivitis is a very common ocular infection. The most common cause is adenovirus. Adenovirus is a non-enveloped double-stranded DNA virus. It is the most common, almost 90% of viral conjunctivitis is caused by adenovirus. The viral conjunctivitis may be sporadic or occur in epidemics. The epidemics occurs in environments such as workplace and also in hospitals. It may occur in schools and it may occur in swimming pools. The spread is this is a highly contagious infection. It is facilitated by ability of viral particles to survive on dry surfaces, and it can survive for weeks. And by the fact that viral shedding may occur, viral shedding can occur for many days before clinical features are apparent. So that's why transmission is very common, and transmission is generally by contact with respiratory or ocular secretions of patients, also including fomites and contaminated towels. So patients should be told about to use separate towels and separate soap and separate fomites. So viral conjunctivitis is highly contagious, so care should be taken to prevent transmission of the disease, and patients should be told. And now the presentation, the spectrum of viral conjunctivitis, it varies from mild subclinical disease to severe inflammation, and severe inflammation with significant morbidity. There will often be a history of a close contact with acute conjunctivitis. There are many types of presentation. Number one is non-specific acute follicular conjunctivitis, and this is the most common clinical form of viral conjunctivitis, and this is typically due to adenoviral infection, and this can be caused by a range of serological variants of adenovirus. The symptoms are a unilateral watering, redness, irritation, plus minus itching, and the patient may complain of mild photophobia. The contralateral eye generally being affected 1 to 2 days later. So if a patient presented one eye involvement, so it may also be viral conjunctivitis. The condition is usually milder than other clinical forms, and there may be accompanying systemic symptoms like sore throat, common cold. The next presentation is pharyngoconjunctival fever, caused by serovars 347 of the adenovirus, spread by droplets within families. There is upper respiratory tract infection in this type. In 30% there may be keratitis, but it is not severe, and symptoms are the same as above, but there is a prominent sore throat. The next clinical presentation is epidemic keratoconjunctivitis. It is caused by 8, 19 and 37 of adenovirus serovars, and it is the most severe ocular adenoviral infection, and because there may be marked keratitis in 80% cases and photophobia, and prominent photophobia. So in the next presentation is acute hemorrhagic conjunctivitis. In acute hemorrhagic conjunctivitis occurs in tropical areas caused by enterovirus and Coxsackie virus. And although other microorganisms may present similarly. The onset is rapid and resolution takes 1 to 2 weeks. There is marked conjunctival hemorrhages. Another is chronic relapsing adenoviral conjunctivitis. Chronic, so it is chronic and it is non-specific, and there is follicular and papillary clinical picture. Follicular or papillary. It can persist over years because it is chronic and relapsing, but is rare and self-limiting. Another is herpes simplex virus. It causes follicular conjunctivitis, particularly in primary infection. It is unilateral and there is skin vesicles. Systemic viral infections can also cause conjunctivitis in, like for example, varicella, measles, mumps. So a situation will be follicular conjunctivitis. The varicella zoster, there is a secondary infection. It commonly causes conjunctivitis and there is ophthalmic shingles. HIV can also cause conjunctivitis. And there is molluscum contagiosum. It is also a pox virus disease, and it affects healthy children and between 2 to 4 years. Transmission is by contact with auto-inoculation. There is chronic follicular conjunctivitis and due to skin lesion shedding of viral particles. So there is chronic unilateral ocular irritation and there is mild discharge. So the eyelash line should be examined in a patient with chronic conjunctivitis so as not to overlook a molluscum lesion. Now about the signs. The eyelid, there may be negligible signs to severe signs. Lymphadenopathy is common. There will be tender pre-auricular lymph nodes. And in conjunctiva, there may be hyperemia and follicles. Here you can see they are typically prominent. The follicles are prominent. Papillae may also be seen in the superior tarsal conjunctiva. And there may be signs of anterior uveitis. Severe inflammation. There will be conjunctival hemorrhages in severe inflammation, petechial and adenoviral infection. There may be chemosis, membranes. Membranes are rare. Pseudomembranes, sometimes with conjunctival scarring after resolution. Here you can see conjunctival scarring. So here you can see the membrane and here you can see the scarring. The keratitis, adenoviral keratitis, there is epithelial microcysts which will be not staining in early stages. There will be punctate epithelial keratitis which will be staining and occur in 7 to 10 days of the onset of symptoms, and they resolve within 2 weeks. Here you can see focal white subepithelial anterior stromal infiltrates. They develop beneath the fading epithelial lesions as an immune response to the virus. They may persist, they may recur over months or years. There may be small pseudodendritic epithelial formations. So, molluscum contagiosum. Here you can see molluscum contagiosum is a pale, waxy, umbilicated nodule on the lid margin. There is follicular conjunctivitis associated with it and mild watery mucoid discharge. Bulbar nodules and confluent cutaneous lesions may occur in immunocompromised patients. Investigations are not necessary. So if there is diagnosis in doubt, then you can investigate, and if there is failure of resolution, Giamsa stain, it will show mononuclear cells in adenoviral conjunctivitis and multinucleated in herpetic infection. Nucleic acid amplification such as PCR is sensitive and specific for viral DNA. Viral culture with isolation is the reference standard but is expensive. Fairly slow, it takes days to weeks and requires specific transport media. Sensitivity is variable but specificity is around 100%. Next is a point of care immunochromatography. This test takes 10 minutes to detect adenoviral antigen in tears. Their sensitivity and specificity are Excellent. The serology for IgM or rising IgG antibody titers to antivirus has limitations, and this is rarely used. Investigation for other causes such as chlamydial infection, it may be indicated in non-resolving cases. Now treatment. The treatment of herpetic ocular surface disease will be addressed in chapter number 7. Spontaneous resolution of adenoviral infection, it usually occurs in 3 weeks, in 2 to 3 weeks. So specific treatment is typically unnecessary. No antiviral agent with clinically useful activity against adenovirus has yet been produced. There is no antiviral. Reduction of transmission risk is very important by meticulous hand hygiene. So patients should be told about meticulous hand hygiene. Avoid eye rubbing, avoid towel sharing. There should be scrupulous disinfection. Instruments and clinical service after examination of infected patient by sodium hypochlorite and povidone iodine. Now the molluscum contagiosum, the lesions are self-limiting in immunocompetent patients. Removal is often necessary to address secondary conjunctivitis or for cosmetic reasons. Topical steroids such as prednisolone 0.5% 4 times daily may be required for severe membranous or pseudomembranous adenoviral conjunctivitis. Symptomatic keratitis may require weak topical steroids, but these should be used with caution because they do not speed resolution. Steroids do not speed resolution but only suppress inflammation, and lesions commonly recur after premature discontinuation. Steroid may enhance viral replication and extend the period during which the patient remains infectious. Intraocular pressure should be monitored if treatment is prolonged. Other measures which are important: discontinuation of contact lens wear until resolution of the symptoms. Artificial tears 4 times daily may be useful for symptomatic relief. Preservative-free preparation may give superior comfort, and if supplied in single dose units may reduce transmission risk. Next is cold or warm compresses for symptomatic relief. Topical antihistamines and vasoconstrictors may improve symptoms, particularly itching. The place of non-steroidal anti-inflammatory drops is not well established, but may be effective in some circumstances such as steroid weaning. They are not thought to be promote viral replication. Another treatment is removal of symptomatic pseudomembrane or membranes. Another is topical antibiotics if there is secondary bacterial infection. And the last is povidone iodine. It is very effective against free adenovirus and has been proposed as a mean of decreasing infectivity. So this was all about viral conjunctivitis.